Full screen for the natural history study.
Yes.
Perfect. Okay. So moving on to an unrelated topic. So completely switch gears from Chiari common data elements, and now talk about what we've called the benign Chiari-1 malformation. This project grew out of an effort to understand what happens to those patients that we see who have tonsil position outside of the foramen magnum, but really don't have any other symptoms. What do we do with those patients? So to give a little bit of background, this paper from the New England Journal in 2007 was an outstanding study done in the Netherlands of 2,000 volunteers, adults, who underwent MRI scans with no symptoms. These are screening MRI scans. And as you can see here, Chiari malformation they found in about 1% of those adults. When you look at a pediatric population, again, I'm a pediatric neurosurgeon, the number is quite a bit higher. This is a study from the University of Michigan. They looked at about 14,000 MRI scans performed. Now, these were not screening MRIs. These were MRIs that were done for a reason. And out of those, they found 3.6% with a Chiari-1 malformation. Some of those obviously may have been had their MRI done because of concern for Chiari, but others, this was probably an incidental finding. So what we've got is a very common radiographic finding, or a relatively common radiographic finding. At the same time, headaches are quite common, and we are pretty confident that a patient who has posterior headaches that are worse with Valsalva, coughing, sneezing, is going to respond well to a Chiari decompression. Similarly, there's consensus in the community that a Chiari malformation with a cervical syrinx, that is an indication for surgery. But what about the patient, the child that has bifrontal headaches and an incidentally discovered Chiari malformation? Is this related to the Chiari? That's something that we don't really know anything about. So what do we do with these kids who may have headaches, got an MRI scan for their headaches, and we see a Chiari malformation? So what we realized at our institution is that we may have a cohort of patients that will help us answer this question. So the purpose of this study was to determine the natural history and the rate of symptom development in children who presented with what we call the benign Chiari-1 malformation. So what is a benign Chiari malformation? We define this. This was our definition for this study, is that a patient who presents with no classic Chiari symptoms. That means they did not have posterior tussive or Valsalva related headaches. They did not have cranial nerve deficits. They did not have sleep apnea. They did not have hydrocephalus, syringomyelia, or any spinal cord T2 signal change. They had nothing that would have been considered an indication for an operation on their Chiari, at least at our hospital at that time. The practice at our hospital over the last 10 years has been to have these patients return for follow-up rather aggressively. So these patients would come back for a scan after about 1 year, and then if they're still normal, no new symptoms, no new findings on their imaging, they would return in 2 years, and then perhaps even again in 4 years after that for repeat imaging. So we have a reasonably good amount of follow-up on this group of patients who did not have an operation because they did not have what we thought was an indication for surgery at presentation. So to do this study, we had to first identify all of these patients. And we did this by reviewing hospital medical records and billing records. Initially, this came up with almost 1,800 patients. But we excluded 1,300 of them because some of them were not followed by neurosurgery. Several of them, when we looked in more detail at their records, they didn't actually have a Chiari-1. We excluded all patients who had had a Chiari surgery already. We excluded the 250 patients who did not have any follow-up with neurosurgery. We excluded anyone who had syringomyelia present at their first appointment. And then finally, we excluded any patient who had surgery within 9 months of their first appointment. These were patients who we assumed when they were initially evaluated, the thought was that they probably had some symptoms that led us to consider surgery, and it just took a while for them to get scheduled. Because our routine practice, if they're asymptomatic, would be to have them come back in a year. So we may have lost some patients that we could have included here, but we wanted to be rigorous with our definition so that anyone who would have had surgery is not included in this benign cohort. That left us with 440 patients that our medical student actually did a very detailed medical records review on all 440 of these patients. And he excluded a couple more based on this records review for the same reasons: hydrocephalus, syrinx, headaches that in looking in more detail actually were Chiari type or tussive headaches, and the other reasons you see there. So this left us with a total cohort of 427 patients that met our definition of a benign Chiari malformation. And as we spoke to before, the follow-up protocol for these patients was to come back for a clinic visit in 1 year with a follow-up MRI scan. If no change, then they came back an additional 2 years after that, and then an additional 4 years after that. This means that we have follow-up evaluations on these kids at 1, 3, and 7 years after their initial Chiari presentation. And here's what our sample looks like. Their mean follow-up duration is 3 years. Their age at initial evaluation is 8 years. Looking in more detail at the length of follow-up, you see that 103 patients had follow-up longer than 5 years. 311 patients had follow-up longer than 1 year. So this is the mean follow-up of 3 years. The majority of the patients were white. We had also a small minority that were African American or Black, and about 2/3 of these patients had private insurance as opposed to public insurance like Medicaid. Eventually, 15 patients in the course of this follow-up went on to have surgery despite being considered benign Chiari at the beginning of the study. 15 patients out of those 427 had surgery. And here are the symptoms or the reasons that they went on to have surgery. So 5 of those 15 ended up developing what we call the classic Chiari type tussive headache. Of those 5, all of them improved after Chiari decompression. 5 went on to develop syringomyelia on their follow-up MRI scans, and of those, 3 got better with surgery. You see here, some had surgery because of a headache that we wouldn't really consider to be a Chiari type headache, but they for whatever reason, the surgeon in these cases decided to do the operation based on headache anyway. And you can see the other things here: cranial nerve dysfunction, sleep study or sleep apnea, weakness, and scoliosis. We tried to determine were any of the variables that we had collected, like age, gender, race, insurance, were those correlated with a likelihood of undergoing surgery. And all of these confidence intervals, you can see, overlap 1. So these are not statistically significant. So there was no way for us to predict which patients are more likely to undergo surgery. If you look at the Kaplan-Meier curve, this is a curve of freedom from Chiari decompression. And I want to point out something important here, that the bottom of this curve, the way that it's displayed here, is 75%. So if this were to go all the way to 0, we would have a much larger curve with all of the patients clustered up at the top. So looking at the way that the survival analysis breaks down, 95% of these children were free of Chiari decompression at 3 years, 94% at 5 years, and 93% at 10 years. So that begs the question, are we following up these patients too aggressively? Do we really need to see them in a year? Do we really need to repeat their MRI scans multiple times? To answer that, we went into a little bit more detail looking at exactly what happened with each of these patients. If you specifically consider the MRI scan, the reason to do an MRI scan and follow-up is to determine if these patients develop a new syrinx. So we'll focus on these patients that had syrinx. There were 5 of them, remember. But if you look here, this syrinx, this patient also developed scoliosis. And this patient also developed cranial nerve dysfunction. So even without an MRI scan, we would have had reason to be suspicious that there may be a problem with these kids. These 3 patients had syrinx and no other symptoms that would be troublesome for Chiari. So if we didn't do MRI scan, we may have missed 3 patients out of 420. That's a rate of around 1%. And that question I leave to you whether that follow-up is necessary, but it's certainly worth considering whether it's cost-effective to do 400 MRI scans to find 3 patients who might need an operation. The other thing that we noticed when we looked at this data was that every patient who went on to have follow-up surgery was a white race, and the vast majority of them had private insurance, not public insurance, not government insurance. And this was a concern, or this is a concern, makes us wonder if the reason that we're able to, or that we find these patients for an operation, is that they are more likely to have follow-up, or they have better access to care. We actually have gone back now and working with some of our socioeconomic researcher colleagues to try to look more in detail at the socioeconomic status of the entire cohort, try to determine if there's a reason why these patients don't come back, do they get the same follow-up, et cetera. So that's a study that's ongoing. So to conclude, progression of imaging and progression of symptoms that warranted surgical intervention in these patients who we considered benign Chiari patients was at 3.5%. So pretty low, but not zero. So we would conclude that these patients should be managed conservatively, but clinical follow-up of these patients is definitely justified. Whether that needs to be done as an in-person clinic visit, or it could just be done with careful instructions about what symptoms to look for, that's something that needs to be decided. And in the future, we'll be looking in more to these socioeconomic disparities in this analysis. And with that, I'll stop and take questions from the audience on both talks. And these are the people who participated in all this research and helped with this. Thank you.
Great, Brandon. Thank you.
Are you seeing us?
Yes, I can see you.
Yes.
Yes, Brandon, thank you so much for your nice presentation. It's a great pleasure for us to listen to your experience. I have a question about for how long time you perform MRI in asymptomatic patients, or just a simple Chiari wall malformation. For how long time?
So we will, if a patient has a Chiari malformation and no symptoms, we will do 1 MRI scan of the cervical spine and the thoracic spine, so looking for syringomyelia. If that patient does not have any evidence of syringomyelia or T2 signal change, then we will, when we were doing this study, all of those patients would get another scan at 1 year. Now we have become less aggressive, and we will see them back for clinical follow-up in 1 year, but not necessarily another MRI scan. So not every child will get another MRI scan now.
Let me ask you another question to you, Brandon. Again, if you see a child who presented
Então, mas eu estou clicando e não está aparecendo.
Então vamos espelhar a tela de novo. Deixa eu espelhar.
Nós estamos com tempo suficiente, está até sobrando tempo. Onde que está aqui? E agora?
Não pode voltar para aquela mesa, só estava naquela.
Aqui. Aqui o monitor.
Organização. Deixa eu espelhar, mas pode fechar.
Agora fecha aqui.
Agora aqui no artigo. Outra escrita aí. Então, esse raio aqui.
Aqui? Tá, peraí, então deu algum. Pronto, vai abrir. Tá pronto. É que estava numa tela.
Okay, Dr. Rocque, can you now see the slides? Can you see the...
Compartilhou. Ah, peraí.
I cannot see the slides.
You cannot see the slides yet.
Aqui, ó. Agora sim.
Okay, yes,
Yes. Okay.
I can see them.
Okay, so this is the first case, a very straightforward case. A lot of this has been discussed here, so just to exemplify that concerns a 4-year-old boy that had a minor head trauma after having slept on a wet floor, which presented two weeks later to our outpatient clinic. At the time of the trauma, kid was brought to the ER having had like bifrontal headaches, normal physical examination. The CT scan was done at the time and displayed like a downward displacement of the cerebral tonsils. And then a brain MRI was requested. So 2 weeks later, the patient showed up in the clinic, had no symptoms whatsoever. Physical examination was clean, no neurological deficits, no more headaches, normal gait, and no signs of knee irritation. And these are the images. So you can see the sagittal incidence showing the downward displacement of the tonsils, way below the 5 millimeters threshold. Then you can see here also the axial cuts and bills, showing like a busy, foramen on here, right? And then it's open for discussion. So what's the management for this asymptomatic patient that had like a head trauma 2 weeks before?
Would you like me to speak to management or audience?
Yeah, the first one is going to be to the audience, right? Thank you, Dr. Rocque. So anyone in the audience want to comment? Dr. Morales.
First of all, I wouldn't do even the MRI in the patient completely asymptomatic. The discovery of the tonsil radiation was incidental, and the reason of the first CT was only the head trauma. So no intervention, even no MRI.
So anybody else in the audience? So Dr. Morales goes for a conservative approach, right? No more MRIs. And Dr. Rocque, would you like to give your opinion on this case, Dr. Rocque? Can you see the imaging there?
Yes, I can see the imaging, yeah. In a child of 4 with tonsils that are this low, I would do the MRI scan after the CT. I would have gotten the image that you have here. So now looking at these images, I'm quite reassured. The only trouble is that sometimes a 4-year-old may have a hard time telling you if they have headache and exactly if they have any symptoms. But 4-year-old is a little bit easier. A 2-year-old is harder because you really can't tell if they're having headache or tingling in their hands or things like that. I would order a sleep study, polysomnogram, for this child, and if that is normal, I would tell them what symptoms to look out for and not necessarily arrange any follow-up.
Okay, thank you very much.
If you have any problems in a... Brando, what kind of sleep problems do you find in this patient? You can change your conduction of this case.
Yeah. This is another area that we've been actively investigating. We have found patients with Chiari malformation because they have been referred to a sleep study for snoring or or somnolence during the day, and the sleep doctors find sleep apnea and then send them for MRI scan, and we discover Chiari. So we have a very good collaboration with our sleep lab, where our sleep doctor wants to see all of our Chiari patients and study them. If the patient has central sleep apnea with an apnea-hypopnea index of greater than 2.5, so that's, if you're not familiar, apnea-hypopnea index is the number of apneic events plus the number of hypopnea events divided by the total hours of sleep. If the AHI is greater than 2.5 with central apnea, then that would be a reason to strongly consider surgery. I don't have good data on whether the sleep apnea gets better yet, but hopefully we'll have that information for you soon.
Okay, thank you. So just to conclude, then we chose a conservative approach, and this kit has been followed up over the period of 8 months, and still very early, but we haven't seen any symptoms whatsoever. And then the questions that we discussed before, they've already been responded, like is conservative treatment the best approach in this case? Anybody want to comment and respond to all those questions?
Travis, this is pretty much, I mean, we've been struggling with a lot of questions today, and we definitely lack a lot of literature regarding most of these questions. This is pretty much one that I think the literature gives us answers. I mean, Brandon has just showed us a great, beautiful study on that. So it's pretty much we got very strong evidence that you can do conservative treatment on these patients. And also, if let's say that in a month this patient's back in your office and he's got symptoms, or he's worse, or he's even, he's got a motor deficit or something that's quite dramatic, it'd still be, at least from a legal standpoint, I mean, it would be kind of background for them. It should be, you know what I mean? So that I wouldn't feel guilty. I don't think I could be off to blame if my patient got worse, because the literature says what you should do is conservative treatment.
And so, yes, over here.
For you, Chiari, sorry, how old is
4 years.
4 years. How can you manage, if you decide for conservative treatment, how can you manage about sports? Do you have some restriction for sports or not, if you decide for conservative?
Dr. Rocque responded very well beforehand, and with different ages, we have different approaches, and sometimes difficult to follow up. But as he suggested, I would also not recommend any restrictions whatsoever. Just to explain to parents that might be from a theoretical point of view, like a higher risk of after like a minor trauma again, or like a more severe trauma to develop like symptoms, right? But it wouldn't prevent the child from doing any sort of exercise or anything at that age and further on. If it's the case. Dr. Rose, you want to comment on that again? About the exercises in
American football. American football.
Right. Yeah, that's something.
yes.
Look, if we all agree that Chiari 1 malformation is not a primary disease, it's a secondary anomaly. In this case, you are not afraid that you have some kind of born anomaly, born malformation, as a cause of this Chiari 1 malformation. Do you not? Do you agree to ask for a CT for the body study?
That's for you to respond, Dr. Rocque. Would you respond to that?
Yeah. I would not ask for a CT of the spine or really any other imaging on this child. I agree that Chiari is probably not a primary pathology, but I don't truly know. I don't think we really know what the problem is. Is it a bony problem with a small posterior fossa? There have been some volume studies, posterior fossa volume studies, and if I recall correctly, they're somewhat inconclusive. So I don't think that bony imaging is going to help us make a decision on this patient.
Thank you. Any other comments or any other topics? Because we discussed before about like follow-up and MRIs, and as he suggested that we do like even symptoms arise, or anyone would do like MRI every year or every 6 months. Dr. Zanon?
Maybe just complete the MRI to see that the conus is well placed and we don't have phylum. Maybe not right away, right now, but maybe next year when we repeat the MRI, probably I will do all the spinal cord study. Even though it's exceptional, it's rare, but before release my anxiety, I will be more comfortable to be sure that the conus is well placed and we don't have terminal final and lymphoma or stuff like that.
Okay, thank you.
Vamos dar seguimento. Segundo